As I alluded to, now we have the pleasure of hearing from Dr. Lingling Du. Again, a colleague of mine in GI medical oncology. Dr. Du went to medical school in Peking University in China and in Beijing, came to Cleveland Clinic for her residency. We actually overlapped as well at WashU in St. Louis. I was just a lowly resident while she was a lofty fellow. And she probably didn't even know who I was. And then we've reunited here at Ochsner, where she's outstanding GI medical oncologist. She'll be talking to us about novel targeted therapies for GI malignancies.
Okay. Good morning, everybody. Thank you all so much for coming. My name is Lingling Du. I'm a GI medical oncologist. Today I'm going to talk about novel targeted therapy for GI cancer. Click this. Here's my disclosure. There are many targets in GI cancers. I only have 30 minutes today, so I'm not going to go over there are many targets in GI cancer, as many as Disney villains in Disney movies. So I'm not going to go over every single one, and I'm not going to talk about immunotherapy because that's going to be another 30-minute talk. I handpicked 6 targets: Claudin 18.2, HER2, BRAF V600E, KRAS G12C, FGFR2, and IDH1 mutations that we're going to go over today. The first is Claudin 18.2, which is definitely one of the newest and hottest area right now. And if anybody knows, the newest Disney villain is this King Magnifico from the Disney movie Wish from last year. Claudin 18.2 is a tight junction protein normally expressed in gastric mucosa cells and still retained in gastric G-junction adenocarcinoma. Zolbetuximab is a chimeric IgG1 monoclonal antibody that targets Claudin 18.2 and leads to cell death. The phase 3 Spotlight trial was presented at ASCO GI last year, 2023, looking at zolbetuximab in the frontline setting in patients with Claudin 18.2 positive, HER2 negative, advanced gastric or G-junction adenocarcinoma. Patients were randomized to receive zolbetuximab plus FOLFOX versus placebo plus FOLFOX. Primary endpoint is progression-free survival. And of course, as oncologists, one of the relevant questions to us is how often do people have Claudin 18.2 positive disease? And in this study, 38% of accessible patients were Claudin 18.2 positive. Response rate was similar, 48% in both arms, but median progression-free survival was better with zolbetuximab plus FOLFOX. It was 10.61 months versus 8.67 months with placebo plus FOLFOX. Median overall survival was also better, 18.23 months with zolbetuximab plus FOLFOX versus 15.54 months with placebo plus FOLFOX. And around the same time, there's another phase 3 GLOW trial with a similar design using zolbetuximab but with CAPOX as a chemo backbone versus placebo plus CAPOX. In the GLOW study, there were more patients recruited from Asian country. It actually showed similar survival benefit from zolbetuximab plus CAPOX. So we have 2 positive trials. The company already submitted a package to FDA. FDA acknowledges its efficacy and safety data. We're still waiting for FDA approval. I know that Mayo Clinic is adding Claudin 18.2 to its molecular testing profile, I think in March, and I think Caris already added Claudin 18.2 to its testing panel as well. Next, we're going to move on and switch gear to talk about one of the largest and oldest target that we have, HER2. We know it all the way from 1998 when we started using trastuzumab for breast cancer. So she's just as old as the evil queen from Snow White. HER2 expression in GI cancer, it's actually quite common in upper GI cancer, we all know. In gastric and G-junction adenocarcinoma, from 7 to 38% of patients would be HER2 positive. Less common in lower GI cancer and colorectal cancer, about 2 to 5% are HER2 positive. Actually more common in biliary tract cancer, up to 20%, and it's more common in gallbladder cancer. Some studies suggest that up to 30% of patients with gallbladder cancer will be HER2 positive. HER2 targeted therapy in gastroesophageal cancer, upper GI, is something that we've been using for a long time, all the way from 2010, when the phase 3 TOGA trial showed that adding trastuzumab to chemo backbone in the frontline setting improves survival for patients with HER2-positive advanced gastric or G-junction adenocarcinoma. The median overall survival was 11.1 months with chemotherapy alone, improved to 13.8 months with trastuzumab plus chemotherapy. So for for a very long time, standard frontline treatment for HER2-positive advanced gastric cancer is chemotherapy plus trastuzumab. And of course, after KEYNOTE-811, it is FOLFOX plus trastuzumab plus pembrolizumab. How about after patient progress in the second-line or third-line setting? The trastuzumab deruxtecan, TDXD, is an antibody-drug conjugate consisting of an anti-HER2 antibody that is linked with a cytotoxic topoisomerase 1 inhibitor. The DESTINY-Gastric01 study is a phase 2 study evaluating the role of TDXD in the third-line or beyond setting for upper GI cancer patients who are HER2-positive. Patients randomized to receive TDXD versus chemotherapy, and the primary endpoint is overall response rate. Overall response rate was 51% with TDXD versus 14% with chemotherapy. Median progression-free survival, 5.6 months with TDXD versus 3.5 months with chemotherapy. And median overall survival was also better, 12.5 months with TDXD versus 8.4 months with chemotherapy. This number looks pretty good, especially this is in the third line or beyond setting. And after that, the DESTINY-Gastric02 study looked at TDXD in the second-line setting. It's a phase 2 single-arm study using TDXD in the second-line setting for HER2-positive advanced gastric cancer patient. Primary endpoint, again, is overall response rate. A total of 79 patients. Response rate was 42%. Median progression-free survival, 5.6 months. Median overall survival, 12.1 months. We all know that TDXD can cause interstitial lung disease or pneumonitis, and this study is similar. In other study, 10% of patients had interstitial lung disease and pneumonitis, and in this study, 3% of patients had grade 5 events. Next, we're going to move lower to the lower GI tract colorectal cancer and talk about HER2 target therapy in colorectal cancer. Again, it's a rare patient population. Only 2 to 5% of patients with colorectal cancer will have HER2-positive disease, but I feel that this is a very small target with a lot of arrows pointing at it already. Again, back to our good old friend TDXD, the DESTINY-CRC01 study is a phase 2 study using TDXD in the third line or beyond setting. 3 cohorts. Cohort A are truly HER2 positive, IHC 3 plus or ISH positive. Cohort B are IHC 2 plus but ISH negative, and cohort C are IHC 1 plus. We all know that for breast cancer, TDXD has very impressive efficacy even in HER2 low disease. So this study is trying to see if we can see the same efficacy in colorectal cancer. This study, they did allow patients to receive prior anti-HER2 agents. Primary endpoint is response rate. In cohort A, response rate was 45% in all patients, and median progression-free survival was 6.9 months. Median overall survival was 15.5 months. In the HER2 low cohorts, there's really not too much impressive signals seen. After that, DESTINY-CRC02 study is a very interesting study. The TDXD test trial in GI cancer that we just talked about, they all use TDXD 6.4 milligram per kilogram. So this study randomized patients to receive the same dose, TDXD 6.4 milligram per kilogram, versus a lower dose, actually the breast dose, 5.4 milligram per kilogram, to see if the lower dose actually works as well. And the other interesting part is this study enrolled patients with both RAS wild type and RAS mutant disease. So the majority of patients with HER2-positive disease will have RAS wild-type disease, but small portion of people will have RAS mutant disease. And we know that for a lot of anti-HER2 agents, if they have RAS mutant disease, a lot of anti-HER2 agents don't work at all. So this study is trying to see for RAS mutant disease if TDXD works. And we can see the result in the TDXD 5.4 milligram per kilogram group, response rate was 37.8%. In RAS wild type, response rate was 39.7%. In RAS mutant disease, still worked. Response rate was 28.6%. Median progression-free survival, 5.8 months. Median overall survival, 13.4 months. This arm did not pale in comparison to TDXD 6.4 milligram per kilogram. So in patients with HER2-positive colorectal cancer, we can use TDXD at 5.4 milligram per kilogram, even if they have RAS mutant disease. The other regimen we can use is tucatinib plus trastuzumab, and that is from the phase 2 Mountaineer study. Tucatinib is an oral TKI that is highly selective for HER2, and trastuzumab, we all know, anti-HER2 antibody, so it's a chemo-free regimen. They enroll patients with chemo-refractory HER2-positive, but they only enroll those with RAS wild-type colorectal cancer. They do not allow prior anti-HER2 agents. First, they enroll patients to cohort A, where they get tucatinib plus trastuzumab, and after expansion, they enroll patients to cohort B, where they still receive tucatinib plus trastuzumab, or cohort C, where they got single-agent tucatinib. Primary endpoint is response rate in cohorts A and B. And the response rate was 38%. Complete response was seen in 4% of patients, which is pretty good considering it's a chemo-free regimen. Median progression-free survival, 8.2 months, and median overall survival, very impressive at 24.1 months. Other than tucatinib plus trastuzumab, there are several other HER2 target therapies that we can use. One is trastuzumab plus pertuzumab, and that is from My Pathway HER2 basket study. In this basket study, 84 patients have colorectal cancer. Response rate was 26%. In KRAS wild-type disease, response rate 30.9%, with a median duration of response 5.9 months. The other one we can use is trastuzumab plus lapatinib. In the HERACLES trial published in 2016, 27 patients received trastuzumab plus lapatinib, response rate 30%, complete response 4%, median progression-free survival 21 weeks, and median overall survival 46 weeks. So to summarize, HER2 target regimens for HER2-positive colorectal cancer, although we don't have that many patients, but we have a lot of things that we can use. If they have not received prior anti-HER2 agents, RAS wild-type, we can use trastuzumab tucatinib, trastuzumab pertuzumab, trastuzumab lapatinib. If they have received prior anti-HER2 agents, if they are RAS mutant, we can use trastuzumab deruxtecan. Next, we're going to move outside of luminal GI tract and talk about HER2 target therapy in biliary tract cancer, as that is a very hot area right now as well. Again, a HER2 expression in biliary tract cancer, up to 20% of patients would be HER2 positive. Tucatinib plus trastuzumab was also tested in a phase 2 basket study in biliary tract cancer in the second line or beyond setting. Again, similar to the colorectal study, they do not allow prior HER2-directed therapy. Primary endpoint is response rate. Response rate was 47%, with a complete response seen in 3% of patients. Median progression-free survival 5.5 months, and median overall survival 15.5 months. These numbers look very impressive considering frontline trial for biliary tract cancer. Median overall survival was approximately 13 months or so, and this is in the second line setting. The other one that has been tested is zanidatamab, which is a bispecific monoclonal antibody directed against two separate domains of HER2. In the phase 2b Horizon BTC-01 study, patients received zanidatamab in the second-line beyond setting. Cohort 1 are those with IHC 2+ or 3+. Cohort 2 are IHC 0 or 1+. Primary endpoint is response rate for cohort 1. And for cohort 1, response rate was 41.3%, with a median duration of response 12.9 months, median progression-free survival 5.5 months, overall survival data not mature yet. And then there's another regimen that we can use for biliary tract cancer that are HER2 positive, trastuzumab plus pertuzumab. That's from the same old My Pathway HER2 basket study, where 40 patients had biliary tract cancer, response rate 22.5%. KRAS wild-type, in KRAS wild-type patients, response rate 25.7%, and with a median duration of response 8.5 months. So for biliary tract cancer HER2 positive, we can use trastuzumab pertuzumab. There's data on zanidatamab, and also pretty impressive data on trastuzumab plus tucatinib. Next, we're going to move out of the HER2 targets and switch gear to discuss also a very old and large target, BRAF V600E, which definitely carries very, very grim prognosis for patients who harbor this mutation. So I think it looked pretty similar to my favorite Ursula from The Little Mermaid, who's an extremely powerful sea witch. BRAF V600E mutation in GI cancer, we can see it in 5 to 21% of patients with colorectal cancer. Less common in biliary tract cancer, 5 to 7%. We all know the good old Beacon study, which is a phase 3 study testing encorafenib plus cetuximab in the second line or beyond setting. Encorafenib is a BRAF inhibitor, and cetuximab is a EGFR antibody. In this study design, patients were actually randomized to one of the three arms. The first arm is a triplet, which include a encorafenib plus binimetinib, which is a MEK inhibitor plus cetuximab. And the second arm is a doublet. Patient receive encorafenib plus cetuximab versus control, where patient gets cetuximab irinotecan or cetuximab FOLFIRI. Primary endpoint is overall survival. Response rate 27% with triplet, similar 20% with doublet versus 2% with control. So the standard of chemo really did not work that well for this patient population. Median progression-free survival was 4.5 months with triplet versus 4.3 months with doublet versus 1.5 months with control. Median overall survival was 9.3 months with triplet, 9.3 months with doublet versus 5.9 months with control. So we can see that doublet arm encorafenib plus cetuximab did pretty well with a better toxicity profile. So encorafenib plus cetuximab is approved in patients with metastatic BRAF V600E mutant colorectal cancer in the second line or beyond setting. So right now, there's an international phase 3 breakwater study. It's ongoing, testing the role of encorafenib and cetuximab in the frontline setting. We have this trial open at Ochsner as well. Currently, cohort 3 is open, enrolling patients with BRAF V600E mutant metastatic colorectal cancer. They are untreated. Patients are randomized to receive encorafenib plus cetuximab plus FOLFIRI versus FOLFIRI plus minus bevacizumab. Patients need to have MSI low disease, or if they have MSI high disease, they need to be ineligible for immunotherapy frontline. So if you all have patients who have BRAF V600E mutation, MSI low disease, colorectal cancer, please, we strongly encourage to refer the patient to us for enrollment, because we know that a BRAF V600E mutation carries a very grim prognosis for these patients. And then a BRAF V600E mutation is seen in 5 to 7% of patients with biliary tract cancer. I happen to have 2 patients with biliary tract cancer with BRAF V600E mutation. We can use a different regimen, dabrafenib plus trametinib for this patient population. That's from the phase 2 RAW trial, which tested dabrafenib, a BRAF inhibitor, plus trametinib, a MEK inhibitor in the second line or beyond setting. Primary endpoint is response rate. A total of 41 patients, response rate was 51%, with a median progression-free survival of 9 months and median overall survival of 14 months. Next, we're going to move on to talk about a one thought to be invincible target, and definitely carries a very grim prognosis, the KRAS G12C mutation. And I signed one of my fiercest villain, that is Maleficent from Sleeping Beauty. Even now, I think that she's pretty invincible as well. KRAS G12C mutation is seen not in a lot, but 3 to 5% of patients with metastatic colorectal cancer. Sotorasib is a KRAS G12C inhibitor. In the phase 3 CodeBreak 300 trial, they tested sotorasib plus panitumumab in the second line beyond setting. Patients randomized to receive sotorasib 960 milligram every day plus panitumumab versus sotorasib 240 milligram every day plus panitumumab versus standard care, test 102 or regorafenib. Primary endpoint is progression-free survival. Ultimately, sotorasib 960 milligram every day plus panitumumab is the winner. Response rate was 26.4% with a median progression-free survival 5.6 months. Overall survival data is not mature yet, but if we have patients with KRAS G12C mutated colorectal cancer, we can use sotorasib 960 milligram plus panitumumab. Another drug that we can use is adagrasib, which is also a KRAS G12C inhibitor. In a phase 1/2 non-randomized study, patients with heavily pretreated metastatic colorectal cancer receive either adagrasib single agent or adagrasib plus cetuximab, a doublet. Primary endpoint is response rate and safety. Response rate was 23% with single agent and 46% with doublet. Median progression-free survival 5.6 months with adagrasib single agent and 6.9 months with adagrasib plus cetuximab. Median overall survival 19.8 months with adagrasib, 13.4 months with adagrasib plus cetuximab, but it's not a randomized study. So right now, there's ongoing phase 3 Crystal 10 trial evaluating second-line adagrasib plus cetuximab versus standard of care chemotherapy. One of the last few mutations that we're going to talk about is the FGFR2 mutation, which is relatively newer but very interesting. So if anybody recognizes it, this is Prince Han, the handsome Prince Han from Frozen a couple of years ago. FGFR gene alterations is seen in 10 to 16% of patients with intrahepatic cholangiocarcinoma. FGFR2b protein overexpression or gene amplification is seen in 3 to 31% of patients with gastric or GE junction adenocarcinoma. For cholangiocarcinoma, we all know there's a couple of FGFR inhibitor that we can use. One of them is pemigatinib. Pemigatinib is an FGFR 1-3 inhibitor. In the phase 2 FIGHT-202 study, patients receive pemigatinib in the second-line beyond setting, 3 cohorts. Cohort A is the patients with true targets, FGFR2 fusions or rearrangements. Cohort 2 are those with other FGFR rearrangements, and cohort 3 have no FGFR alterations. Primary endpoint is response rate in cohort 1, and in cohort 1, response rate was 35.5%, median progression-free survival 6.9 months, and median overall survival 21.1 months. So right now, there's ongoing phase 3 FIGHT-302 study testing frontline use of pemigatinib plus chemotherapy in this patient population. Another drug we can use in cholangio is futibatinib. It's an FGFR 1-4 inhibitor. Similarly, from the phase 2 Phoenix CCA2 study, patients who received futibatinib in second-line beyond setting, primary endpoint response rate. And response rate was seen in 42% of patients, median progression-free survival 9.0 months, median overall survival 21.7 months. Similar phase 3 Phoenix CCA3 study is ongoing, testing frontline role of futibatinib plus chemotherapy for patients with FGFR2 rearranged cholangiocarcinoma. Moving outside of cholangio into the upper GI tract, FGFR2b protein overexpression or FGFR2 gene amplification is seen in certain number of patients with upper GI cancer. Bemarituzumab is an FGFR2b monoclonal antibody. In the phase 2 FIGHT study, patients randomized to receive frontline bemarituzumab plus Fofox versus placebo plus Fofox. Primary endpoint is median progression-free survival. Of note, 30% patients screened were positive for FGFR2. Response rate was 47% with the bemarituzumab plus Fofox group versus 33% with placebo plus Fofox. Median progression-free survival, 9.5 months versus 7.4 months. Median overall survival was significantly better, 19.2 months with bemarituzumab plus Fofox versus 13.5 months with placebo plus Fofox. So right now, the phase 3 FORTITUDE-101 study with similar design is ongoing. And lastly, we're going to talk about a mutation that definitely carries a very, very grim prognosis, IDH1 mutation. And if anybody recognizes, this is Drune from Raya and the Last Dragon. It's basically a fire monster that engulfs everybody on its path and turns all people and animals into stone and ashes. IDH1 mutation is seen in 13% of patients with intrahepatic and 1% of patients of extrahepatic cholangiocarcinoma. Ivosidenib is an IDH1 inhibitor. In the phase 3 Clarity study, patients with pretreated cholangio with IDH1 mutation randomized to receive ivosidenib versus placebo. They did allow crossover. Primary endpoint, progression-free survival. Response rate, not that much, 2% with ivosidenib, 0% with placebo. Median progression-free survival, 2.7 months with ivosidenib, 1.4 months with placebo, but after adjustment for crossover, median overall survival was significantly better, 10.3 months with ivosidenib versus 5.1 months with placebo. So if our patients with cholangio have IDH1 mutation, we definitely can use ivosidenib. Take-home points, novel target therapies demonstrate promising efficacy in our patients with advanced GI cancer. Available targets that we have right now for upper GI cancer, gastric, GE junction endocarcinoma, we have Claudin 18.2, HER2, FGFR2. For colorectal cancer with HER2, BRAF V600E, KRAS G12C. For biliary tract cancer, we have a lot of targets, HER2, BRAF V600E, FGFR2, and IDH1 mutations. The key, and that's the entire goal of my total talk today, is to emphasize on testing. All our patients with advanced GI cancer undergo next generation sequencing, and we should also be stating for Claudin 18.2, HER2, et cetera. We would never know we can use these wonderful drugs if we never tested our patients for that. And of course, enrolling in clinical trials is key, and that's how we come to know that we have all these drugs that we can provide for our patients. Thank you.
Tour de force, Dr. Du. Any questions for Dr. Du? One thing I'll note is that when she speaks, even though she had 30 minutes to get an hour's worth of content, so thank you for that. All right, so the next portion here we're going to move into is our panel discussion. So I'll have Dr. Dude, Dr. Higbee, and Dr. Pointer, if he hasn't left yet, there he is, come up, and I'll do a couple cases, and feel free to interrupt with any discussion or questions for our panelists with these discussions, and I'll try not to be too squirrely. Is that what you said? Squirreling.
Are we sitting or standing?
Why don't you sit, or else I feel weird. Okay, so I'm going to do 3 cases here, and they're 3 different diseases, and just want to the most important thing is not the specifics of the case, but kind of talk through how we approach these from a multidisciplinary state. So the first case is a 68-year-old female. She has no significant past medical history. Comes to the ER with worsening generalized abdominal pain for 2 weeks. She has this imaging on her CT scan. Can y'all even see it?
I can see it in the mirror.
The reflection on the mirror? Yeah, okay. You probably need to see it the most since you're a surgeon. Okay, so basically the radiologist read this as an 11.5 by 7.8 centimeter mass involving virtually the entire left lobe of the liver and with extension into segments 4 and 8. So a large liver mass, virtually all of the left liver lobe, as you can see, and you can see kind of what I would call satellite lesions extending into the right lobe as well, maybe something here, and then there, that guy there. Can I get to the biopsy,
Yeah,
Dr.
sure.
Pointer? Come on. Biopsy showed an invasive, moderately differentiated adenocarcinoma. The immunohistochemistry staining profile on this was a CK7 positive, CK20 negative, CDX2 negative tumor. So now I'll kind of open up to you guys. So you have this large left liver mass on the CT abdomen. This is the IHC, again, CK7 positive, CDK20 and CDX2 negative. What are you thinking? What other testing are you recommending at this point in time for this patient, assuming you have all the luxury of tests?
So just looking at the imaging alone from a surgical perspective, can you go back to it? The mass itself is pretty complex. This is locally advanced, if not metastatic. It's hard to tell if there's true satellite lesions or not. And then looking at the staining, it looks like it's probably a foregut or hepatobiliary origin. So, I think there's several next steps, such as staging and scopes and things like that. But I'll pass it on to you guys, see if you guys had any other thoughts.
Yeah, I mean, I agree. I'd complete staging and with any question for the primary source. I mean, certainly even with maybe suspicion of a hepatobiliary or something like that, then I would still definitely rule out an upper GI or something like that. And at some point with this type of tumor, definitely want to do some molecular testing as well.
Yeah, I think we usually do a PET scan and EGD and a colonoscopy.
Yeah, I completely agree. So, all of these were done. So I'll start here with a PET scan. And the PET scan showed, what you can see here is that same mass we saw on CT was very hypermetabolic, SUV into the 20s. You see these, I think now we can clearly see extending into the right lobe, probably satellite lesions, meaning probably not contiguous spread, so spread into other parts of the liver. And then what I will note as well is this patient had a mediastinal lymph node as well, so subcarinal lymph node you see in the kind of right-sided imaging here. So patient had EGD, no mass seen, no tumor seen, colonoscopy, no tumor seen. So what would you recommend at this time? What's your diagnosis? I think you kind of alluded to it, but what would you say, either of you guys?
Intrahepatic cholangio.
I'll just say, we didn't talk about tumor markers as well. Sometimes those can be helpful, like if you have a really elevated CA19-9, but we do often see with these really bulky dominant masses, even with some of the satellite sites, that's quite consistent with intrahepatic cholangio. Oh, yeah.
Yeah, I think the other thing to stress, we have, if you go back to the PET, now you can really see we do have satellite lesions within the liver. So based off the criteria, this is likely intrahepatic cholangio, like my colleague said. But from a surgical perspective, this is also stage 4 disease because there's multifocal disease within the liver. So even though it's all in the same organ, this patient at this point is not an operative or surgical candidate.
And then the node as well, obviously. But yeah, so even if you didn't have the distant lymph node, which obviously makes it stage 4, I think to Dr. Pointer's point is that there's not an operation that could clear this patient of disease. He says we're not that good. Then we'll have to go elsewhere. Just kidding. So one thing I will note is that I think a lot of these patients still will carry a label of cancer of unknown primary, and we still see that. When you see this immunohistochemistry profile and you see this picture and they've had negative scopes, I don't think you need to go fishing for something else. I think we have an answer. There's not going to be a bright red light that says this is an intrahepatic cholangiocarcinoma, but I think once you've ruled out other sources in the right clinical context, 99 times out of 100, this is an intrahepatic cholangiocarcinoma. And I think that matters for a couple reasons. One is treatment, one is prognosis, and then one is also when you're looking for those molecular profiles, or you're doing your NGS testing, you're going to have hopefully a higher rate of finding something that is actionable. Okay, so now we have a diagnosis, what is presumed intrahepatic cholangiocarcinoma, stage 4, treatment options.
Like you said, for biliary tract cancers, we absolutely want to look for any mutations that potentially have targets. But, standard of care first line for this patient, I would start gemcitabine, cisplatin, and durvalumab.
Yeah, either the TOPAZ-1 regimen or, of course, clinical trial if we have one.
Would you wait for molecular profiling to come back before starting this patient? Assuming that you see them, you get the diagnosis, you test them all at the same time, or would you wait for the molecular profiling to come back before making that decision?
At Oshna right now, we don't have frontline, but if we have frontline and they request a molecular marker, we may wait for that molecular marker.
The frontline trial, you mean?
Yeah, frontline trial. Mm-hmm.
Okay.
Yeah, I would say the same thing. I think it depends on, how compelling the clinical trial option is, as well as maybe patient considerations as well, like performance status and liver function too. A lot of these patients, I get concerned about waiting too long to start something, so may just go with first line.
Great, yeah, I totally agree. So if you have a first line trial, like Dr. Dew alluded to first line FGFR2 trials, so you would need to have that profile back before potentially enrolling on the trial. If you don't have the trial, the only one I would probably make sure you have back, in my opinion, would be the MMR MSI testing. So if you have that back and you have MSI high, obviously one could still offer GemCis with immune checkpoint inhibitor, but I think the option would be open up of doing immune checkpoint inhibition alone. Is that fair? Mm-hmm. All right. So a question I'll ask in a second too is, Dr. Pointer, do you ever see a role for this patient, let's say they had a great response to systemic, ever having a local regional therapy option down the line, whether that's surgical or IR or what have you?
I think that's a tough question. I think we would probably not consider that unless the patient had undergone a significant amount of systemic therapy and had a meaningful response, which is uncommon, unfortunately. But I think there are situations maybe where patients respond and have a single dominant lesion or something else, and maybe we would consider it in that case, but it's certainly not the standard of care.
And I'm going to contrast that with our next case, which I won't get into quite yet, but with a colorectal cancer. So if this were a different malignancy, which I think is an important distinction, would you have potentially a different response?
Yeah, for sure. I think we have probably 5 or 6 options for patients with metastatic colorectal cancer. So the disease process matters. The aggressive nature of the pathology matters. So yeah, it would be a different answer for sure.
So this patient actually had an actionable mutation. So this patient had an FGFR2 fusion. So the fusion partner was CCSER2. So with that knowledge, this patient at this point had already started on GemCis durvalumab. How do you make a decision Would you ever switch the patient in the middle of first-line therapy? Do you wait for second line? What would you use in the second line if you are waiting? What are your thought processes with this, either Dr. Higbee or Do?
I'll just briefly say that what I reiterate over and over again to my patients is that if we're on effective therapy, I'm unlikely to stop unless it's not well tolerated. So I think if gemcitabine is effective and the patient is tolerating well, then I would save any targeted therapy for second line. Maybe I'll let you.
Yeah, if patients responding to frontline, then we continue with it, because all the data that we just discussed on targeted therapy for cholangio, like off clinical trial, everything is in the second line setting. So we can certainly wait for second line to start FGFR inhibitor.
Great, and just to close out this case, so I agree completely. This patient had an excellent response to first-line gemcitabine. This patient's still on gemcitabine, and they're almost a year into treatment. So even though it's always like that tempting option to go to that, I would also not use it unless there's a reason to. One thing I also know is that the fusion partner of FGFR2, everything I've read thus far shows doesn't really matter. I think there's different prognostic and maybe predictive effects of what that fusion partner is, but it's fusion partner agnostic of what the FGFR2 fuses with in terms of the efficacy. All right, making sure I didn't say anything wrong there. All right, let's go to case 2. So this is a colorectal case, so I just gave it away. But she's a 44-year-old female. I thought that was in the first slide, oops. 44-year-old female, no past medical history, comes to the ER with abdominal pain, nausea, vomiting, constipation, and she has this scan. Can you see that one, David? All right, so basically, predominantly right lobe disease, and definitely separate lesions there. I already told you it was colorectal in origin, so these are metastases. The next workup she did have a colonoscopy, which showed a fungating, completely obstructing large mass in the mid-sigmoid colon, and it was circumferential, oozing was present, and they took a biopsy. So this was completely obstructing. And what would you do as a next step, really, any of y'all?
Okay.
I think they're
All right, so if you go back to the scan, similarly locally advanced appearing lesion, but knowing the pathology and the origin, I think our approach is a lot different. And I also want to just stress that if you're seeing these patients in your practice setting, we have a lot of options for these patients. We treat them a lot differently than some of the other primary liver cancers that we see. What's important, I think, in the history, though, is that the patient's primary is obstructing. It sounds like they're having some symptoms, or if they're in the ER, I can't remember what you said. So honestly, that's really the first thing that needs to be addressed, because that's life-threatening. So that's a surgical problem. Typically, that's done if we can get away with it, not emergently, but if it has to be, it can be. That patient can be diverted. We typically do not recommend proceeding with primary resection, but we do see that on occasion. But I think a diversion to relieve the obstruction and then continue the workup and get this patient initiated on some level of systemic therapy first would be my option. Now, I said we have a lot of options. I think we'll get there, but oftentimes we want to get these patients on systemic therapy to try to initiate some kind of response, also to assess disease biology and just see what we're dealing with. Well,
clearly he's a very smart surgeon, because that was done. This patient had a transverse loop colostomy performed urgently, so they either that day or the next day, they took this young lady to the OR, diverted her, and then they went ahead and biopsied a mass that was in the liver. It showed adenocarcinoma, so again, different from our last IHC profile. This one was CK7 negative, CK20 positive, CDX2 positive. Not to make a huge discussion over this, but fits with a lower GI primary, a luminal lower GI primary. What other testing at this point would you recommend for the patient? They see you in clinic, they've been diverted, they're feeling better, but now they want to see their medical oncologist and say, all right, what are we going to do now?
So other than, I can't remember if we did a full CT, but obviously we want to do full staging to understand, exactly the extent of disease. But I totally agree that systemic therapy should come first. The kind of, as you mentioned in the prior case, probably the most important marker that we want to check is going to be mismatch repair status, which typically comes back pretty quick. So would certainly want to get that, as well as, I often try to get BRAF and RAS mutation status for first-line therapy. Those can typically all be done kind of while you're getting the patient set up for standard of care first line. And then would of course also want to send full NGS for kind of future planning. But I agree, always starting with systemic therapy makes sense.
Yeah, I agree. Usually we get by the time patient come in to see us, we get MSI result already. And then we do like the KRAS, BRAF, we actually send NGS, and the liquid NGS, usually we get results back within 2 weeks. So that actually gives us result pretty quick.
Great, totally agree. So we have some of the data back. So she has a microsatellite stable tumor or proficient MMR proteins. She's RAS-RAF wild type. She does get full tissue NGS, which shows an APC and TP53 mutations. TMB 8.7. Her HER2 is negative by IHC, and she was not ERBB2 amplified on her NGS. So I would ask, what systemic treatment would you recommend? So again, her primary was kind of sigmoid colon. She is RAS wild type, RAF wild type, HER2 negative. So what would be your approach to systemic therapy in this patient?
Usually I do a chemo backbone plus anti-EGFR if left-sided and RAF wild type.
Totally agree. I think, how old is the patient?
44.
Yeah. I think the only other consideration here, typically I would probably start with most patients with metastatic disease, something like FOLFOX with an anti-EGFR if there were no contraindications. I think for a 44-year-old, and if the surgeon's telling me that down the road could potentially be resectable, the only other thought would be to start with triplet therapy. In that case, my practice is to actually pair it with bevacizumab just for tolerance and to kind of save something for down the road if we need it. But that would be the only other consideration, would be to treat this patient a little bit more aggressively if we thought that, if we got a good response, could get her to surgery.
Yeah, I think that's exactly right. So this is one of my patients, and I had the exact same debate in my head of whether, I think the data actually is not great if you're going to use a triplet and EGFR, right? So if you are going to do a triplet, so when I say triplet, we're talking about FOLFOXIRI or FOLFIRINOX, so adding kind of all your cytotoxics together at once in the front line, and then what you would add as your biologic. Really, I think in that case, the data shows that it should be bevacizumab. If you are going to do a doublet, then I think that opens up potentially anti-EGFR, and I would actually recommend anti-EGFR in that setting. We know that there is a survival benefit of anti-EGFR left-sided RAS wild type. And then I think it was some study that, I forgot the name off the top of my head, but it was presented at last year's ASCO GI. I think that if you actually do like a hyper selection of patients who are going to be treated with anti-EGFR and really kind of dissect down to their like every negative mutation, then you can really predict the ones who are going to have the most benefit from it. So I think this would be a patient where either of those options I think are reasonable. If you want to go for kind of most response, I think the triplet with bevacizumab. If you're saying let's play the long game, and I think EGFR with a doublet would be totally appropriate. Okay, so I don't have more on this patient, but I do want to kind of get to that stuff we were alluding to with Dr. Pointer. Let's say she has a very good response. What kind of things would you be thinking about in terms of managing? Obviously, we have to think about the primary at some point if we are going to go after the liver, but what kind of offerings could you have for her down the line? I'm just going to pull up her images again.
Yeah, so I think to start off, it's important. We really like to see these patients at the beginning at their diagnosis so we can make sure they understand what the potential options are in the future. But depending on the response to systemic therapy and how they tolerate systemic therapy, there's numerous options, and they range from surgical resection, staged surgical resection where we would clear one side of the liver, come back another day to do the other side of the liver, ablation, Y90 radiation, and then other things such as hepatic artery infusion pumps, which we just started a program at Oxygen. We did our first patient last month. What else am I forgetting? And transplant. Transplant is always another option as well. It's tricky when the primary is intact, so there's I wouldn't say it's controversial, but there's debate as to how we handle that. Our preference is to handle the liver disease first, since typically that is the disease that's going to affect the patient's or overall survival or outcomes the most. So we try to address that first, especially if the primary is not obstructing or has already been diverted. If the stage operation is offered and the patient's a candidate for it, oftentimes we'll address the colon potentially at the time of the smaller smaller operation of the two stages. But this is very patient dependent, and this takes a lot of discussion with the multidisciplinary team and the patient. And this is why we have dedicated tumor boards and things like this for these patients, because there's a lot of options available to them, especially if they're responding to systemic therapy well.
Great. Yeah, I think that's the full panel of offerings that we have. Just one thing I'll echo is just let's get these patients early. So the earlier they see kind of the surgical team, the more options I think they'll have down the road. So they haven't seen 6 months of oxaliplatin. They become a less appetizing patient to operate on in the liver. Take my word for it. I've done a lot of these liver surgeries. That was sarcastic. And also I was thinking about the paradigm study. It just came to me a second ago. So anyway, all right, so great. So, lots of options for these patients if they have a good response in the liver, and really getting them seen early by surgery, in my opinion, is the best. Okay, so I'll quickly move to the last case, case 3, 67-year-old male, type 2 diabetes, hypertension, 10-pound weight loss, vague epigastric pain, abdominal bloating. They had a CT abdomen pelvis with contrast. If you can make it out here. So they have a head of pancreas mass, really an uncident head, pancreatic ductal dilatation, intra and extrahepatic biliary ductal dilatation. So you have an obstructing pancreatic head mass. Let's see if I can show it on this one. This guy up here. And the mass abuts the SMV, and there's really not any other clear contact with any other vessels. So just abutment of the SMV, no caliber change, and then portal vein, SMA, celiac are all open. What further workup? I think a lot of these patients end up seeing surgical oncology first. So, Dr. Pointer, what workup would you recommend at this time?
Yeah, I think initially you would have to just see what the lab showed. If they're obstructed from a biliary standpoint, they may need an ERCP or some type of intervention to relieve the biliary obstruction. And then after that, we'd proceed with staging and try to obtain some type of diagnosis, really. So during an ERCP, oftentimes an EUS can be performed and they can get tissue diagnosis for us. And when we get that, we can proceed with appropriate staging.
Great. So this patient had an endoscopic ultrasound. They also had a CT chest that showed no metastatic disease. And the endoscopic ultrasound showed a mass in the uncinate process. They staged as T3 and 0. So they didn't see any lymph nodes. They did do an FNA, which showed adenocarcinoma. So how would you stage this patient in terms of the conventional staging we use for pancreas cancer? We haven't talked a lot about pancreas cancer today, but in pancreas cancer, we don't typically use stage 1, 2, 3, 4. Obviously, you can, but in terms of these localized setting, how would you characterize this patient? I don't know which of you wants to take this, and what your next step would be after that.
Okay, I can just from a surgical anatomic perspective. So we look at vessel involvement and what the tumor relationship is to the arterial venous structures. To determine which bucket the patient falls into. So we have 3 real buckets. We consider patients resectable if they have no true or significant involvement of the vessels. We do call them resectable if there is some abutment of the venous structures. But typically, if there's significant venous or venous and arterial involvement, we'll put them in a category that we call borderline resectable. And then the final category is locally advanced, which means there's significant involvement to the point where we don't even think that those vessels can be reconstructed in surgery. And that's probably the worst bucket to be in if you're a patient with a new diagnosis of pancreas cancer.
And then what about approach to treatment? So this patient, I think, would fit in a resectable category. There's really abutment, so it's touching the SMV. It's not really obstructing its flow. It's not encasing it. No arterial involvement, so we'd say a resectable. So NCCN guidelines would offer a couple different strategies for this. One would be, just for sake of time, I guess I'll answer this. So one would be just going ahead with upfront resection. The other would be doing neoadjuvant therapy and perioperative therapy. So either way, you're going to need 6 months of chemotherapy. FOLFIRINOX is the Category 1 recommendation based on the PRODIGE study. And our typical approach at Ochsner, for a variety of reasons that maybe we don't have time to get into right now, is to do upfront neoadjuvant chemotherapy. You're testing the biology, you're testing the patient, you're potentially weeding out or treating micrometastatic disease. We think of pancreas cancer as really a systemic disease even at the time of diagnosis, and then going ahead to surgery, and then finishing out the adjuvant chemo to complete 6 total months. Any additions there? That covered it. Okay, so I'm going to throw one curveball at you. You get adenocarcinoma, and when you're just about to start that FOLFIRINOX, you get this result back, and the patient has loss of PMS2. Now what? I'm going to ask Dr. Du to answer this one, since she's had experience with this exact situation.
Oh, she's my patient. That's a good question. So for MSI-high cancer, we know that they probably will have a very high chance of responding to immunotherapy, although for resectable pancreatic cancer, like not in locally advanced and resectable, we don't really have strong data supporting like neoadjuvant or adjuvant immunotherapy. But as a clinician, I would highly favor treating them with immunotherapy.
Any different? So upfront immunotherapy instead of surgery? I'm not disagreeing with you. I'm just confirming.
I mean, I can say, I think anecdotally, that sounds great. We've had a few cases like this, even locally advanced, that have responded really, really well, almost complete response radiographically, and we debate whether surgery should even be offered. But we don't really know the answer, right? So I think the right answer is whether we treat or not, eventually the patient should probably have surgery if they're resectable and a good candidate. But the radiographic responses that we've seen 2 or 3 in the past year that have been remarkable.
I'll just add, I probably would do the same thing. I mean, I think that, obviously pancreatic cancer is different than colorectal cancer. The response to immunotherapy is a little bit different as well, but kind of extrapolating from that, we know that these patients also tend to not respond to chemotherapy or traditional chemotherapy as well. So I think immunotherapy is really appealing in that sense.
Yeah, I totally agree.
I think it's up to whether insurance company would like to cover immunotherapy.
That's true as well. I think when you think about pancreas cancer, though, is even in a resectable pancreas cancer, you get them to surgery, you get 6 months of chemotherapy. I mean, I think best case scenario, you're still looking at a 50-50 chance at best. It's probably even a little bit lower than that, of having a cure in a patient. And that's going through, and this patient will be a Whipple, and then all of the chemotherapy. So I think offering them a certainly most likely less toxic approach that probably, in my opinion, has a higher chance of curing them than 50-50, and certainly seems like a very reasonable thing to do. And they agree. All right, well, that's the last case, and I appreciate all 3 of you guys coming and speaking and answering questions, and thanks for listening. I think it's time for lunch.